Good afternoon, everyone, and welcome to the 18th Annual Howard L. Bost Memorial Health Policy Forum, brought to you by the Foundation for a Healthy Kentucky. I am Allison Adams, Vice President for Public Policy at the Foundation, and I'm delighted to welcome you today. As so many of you have, we too at the Foundation have had to adjust to COVID-19. And so we are doing the forum a little differently this year because of the pandemic. Instead of meeting together for a full day, we've turned the forum into a monthly webinar series. And we're delighted that you have chosen to join us this afternoon for the second webinar in the series. The Foundation for a Healthy Kentucky is a nonprofit, nonpartisan 501c3 organization that has one goal. We work to improve the health of Kentuckians. Toward that end, we offer this forum free of charge in memory of Howard L. Bost. The forum is designed to highlight programs and policies that, based on real-world evidence, actually improve health. We believe that bringing together advocates, providers, and policymakers to learn about these programs and policies can help Kentucky adopt, implement, and expand health improvement success stories. In that vein, I'm very excited to announce to you today the launch of the Kentucky Coalition for Healthy Children, which is now seeking members. The Foundation is the backbone organization for this coalition, which will work to identify and promote policy priorities to improve children's health in the school setting. To learn more about this coalition, please visit the website KentuckyHealthyChildren.org. Now on to today's event. The title of this year's Bost Policy Forum is Moving Kids Toward Natural Highs, and we're focusing on programs and policies that help move Kentucky kids away from substance use, suicide, and other risky behaviors, and towards more natural highs, healthy behaviors that will benefit them throughout their lives. This is the second of 5 webinars, and we hope you will join us for each of the others. Our partner in this year's forum is Kentucky's Youth Advocates, the Commonwealth's independent voice for kids. I appreciate all the staff, and I know you join me in thanking them for their work to improve child well-being in our state. I'm happy to introduce today's moderator, Tracy Antle. Tracy is the Chief Operating Officer for Cumberland Family Medical Center, a federally qualified health center with clinic locations in 26 Kentucky counties. Tracy serves on the Foundation's Community Advisory Council, as well as the Board of Directors for the Kentucky Health Center Network. She is a member of the National Association of Community Health Centers, where she serves on the Rural Health Committee and the Membership Committee. I'll now leave you in her very capable hands. Tracy?
Thank you, Allison, and welcome everyone. The title of today's webinar is The Intervening Early. It follows our first webinar in the series held September 21, entitled The State of Child Health in Kentucky. Today's focus is on programs and policies for interventions that can be introduced in the earliest years of our children's lives to greatly reduce the likelihood of risky behaviors and disease in adolescence and beyond. Speakers will discuss programs based in the home setting, in schools, and in physician offices that set infants and toddlers up for better health throughout their lives, especially in light of the COVID-19 pandemic. We have 4 speakers today. I'll introduce them, and each will speak for about 10 minutes. Then we will open the webinar for audience questions. A couple of housekeeping items before we get started. All audience and speaker microphones should now be on mute. This helps reduce background noise. If you're posting on social media about this webinar, and we welcome you to do so, please use the hashtag 2020BostForum. You are welcome to write in your questions at any time during the webinar. You don't need to wait until the question and answer session at the end. Just type your question whenever you think of it in the box at the bottom of the webinar screen, and if you want an answer from a particular speaker, please note that person's name so I can direct the question accordingly. I will try to get to every question during the live webinar. However, if I do not get to yours, please know that we will capture the questions and get a response to you later following the webinar. Finally, as I noted, these webinars are recorded and then posted on the Foundation for a Healthy Kentucky's website. The link is on your screen, and we'll show it again at the end of today's webinar. And now I'd like to introduce our first speaker. Lisa Lee is Commissioner for the Department for Medicaid Services at the Kentucky Cabinet for Health and Family Services. She has 20 years of experience with Medicaid programs and had retired from state government in 2016 and worked as a healthcare consultant for 3 years before returning as the Commissioner in 2019. Previously, Commissioner Lee had served in a variety of roles within the department, including Director of Provider Services and Deputy Commissioner. In addition, she was Program Director for the Kentucky Children's Health Insurance Program, KCHIP, for approximately 14 years. At the national level, Commissioner Lee has participated in several work groups aimed at improving the health of children and delivered a variety of presentations related to the Medicaid program. Commissioner Lee?
Thank you. Good afternoon, everyone. I'd like to thank the Foundation for a Healthy Kentucky for hosting this platform to allow me to provide some information related to Medicaid's role in children's health. Many of you have heard maybe Medicaid and KCHIP and wondered if there is a difference between the two programs, and there is a difference. Specifically, Medicaid, individuals enrolled in Medicaid can have other insurance. They also have an early periodic screening, diagnosis, and treatment benefit, which we will get into a little bit later in the presentation. Also, individuals enrolled in Medicaid have non-emergency transportation benefits. Children enrolled in KCHIP cannot have other health insurance. They have to be under the age of 19. Their family income has to be up to or below 200% of the federal poverty level. And children enrolled in KCHIP cannot receive EPSDT or NEMT benefits. However, I'd like to note that Medicaid and CHIP both do use managed care organizations to administer care for children in the Medicaid and CHIP program, and some of those MCOs actually will provide those EPSDT benefits. So we'll get into that in just a little bit. So when we talk about federal poverty level, I've listed the 2020 federal poverty level here for individuals who can enroll in Medicaid and CHIP. Children with family incomes at or below 200% of the federal poverty level are eligible for CHIP. I've also listed a couple of other federal poverty levels in here. For example, the 138 federal poverty level, or FPL, is for individuals, particularly adults, who can enroll in the Medicaid expansion population. And we know if adults and parents are enrolled in health insurance, Medicaid, then more likely their children will be enrolled also in insurance. So it's a good way to get a broader base of child enrollment in Medicaid. I've listed the 400% FPL here just as a marker to let individuals know that if parents or adults over 200% or over 138% of the federal poverty level can't qualify for Medicaid, but if their income is over 138 and up to 400% of the federal poverty level, they can enroll in a health insurance product on the state-based exchange, which will be Connect starting in 2022. And again, the more likely that an adult is covered, the more likely they will get their children covered. So those federal poverty levels are really important when we talk about Medicaid and KCHIP. Currently, Medicaid has 646,193 children enrolled in our program, which is a little right at either a little over or about half of the children in the state are enrolled in Medicaid. The benefits children receive when they enroll are mandatory and optional benefits. All of the mandatory benefits include inpatient hospital, outpatient hospital services, and here we have the EPSDT benefit. Now, the EPSDT benefit, it's early and periodic screening, diagnostic, and treatment services. What this benefit says is if a child needs a medically necessary covered service, the state has to provide that service regardless if it's covered under the state plan or not. So Medicaid operates on a state plan basis that has been approved by Center for Medicare and Medicaid Services, or CMS. So all of those optional benefits that you see over there are actually included in the Medicaid program. And the benefit that I like to give the best example of is dental services. Children in Medicaid and CHIP can receive 2 dental cleanings per year. Sometimes we have children with special health care needs that makes it very difficult for them to have really good oral hygiene. So because we only cover 2 cleanings per year, a child can actually get a 3rd cleaning through the EPSDT benefit, or 4th or 5th. So a child enrolled in Medicaid and CHIP should never be denied a service because it's not medically necessary. So I think that's a really important benefit specifically for children that as we move forward, we talk about things that we can do to prevent risky behaviors and give children the lives, give them things that they can, so that they can lead their best life, services. And we need to keep that in mind, that the array of benefits in Medicaid and CHIP is quite expansive and here specifically for children. So again, I just talked about the EPSDT benefit, and that is actually for children under the age of 21. Some other programs specifically for children that's covered through Medicaid is the Health Access, Nurturing, and Development Services, which is HANDS. This is a home visitation for first-time or at-risk parents. And this program is not only available to Medicaid enrollees, but it is also available to individuals who are not enrolled in Medicaid. First Steps is another program specifically for children. It's an early intervention program for children from birth to age 3. Again, this program is available to Medicaid enrollees as well as individuals who are not enrolled in Medicaid. And both of these programs are conducted in a collaborative effort with the Department for Public Health. We also have a Title V program, which is a collaboration between Medicaid and the Department for Community-Based Services to specifically provide services for foster children. As I mentioned earlier, Medicaid uses managed care organizations to administer care for adults and children. And managed care organizations can provide value-added services, and many of them do. So an example of a value-added service would be, for example, maternal health. Some managed care organizations provide incentives for pregnant women to complete all of their maternal child visits, and they will either give them maybe a stroller or a car seat when they complete all of those visits. The MCOs are responsible for reporting well child visits and screenings to the department, so we can keep track of the number of children who are receiving their visits, identify areas where there may be gaps, particularly in rural areas versus urban areas, and try to make sure that all children receive their well child screenings. In state fiscal year 2020, the MCO spent $2.3 billion, that is billion with a B, dollars on children's health care services, versus Medicaid spent $684 million for fee-for-service, and we'll get into that just a little bit. And beginning on January 1st of 2021, all children who are enrolled in the foster care program will be enrolled with one managed care organization, and that will be Aetna, and it is through the SKY program. It's called Serving Kentucky Youth. So this may be a little small for you to read, but I thought it would be interesting to look at the top diagnosis codes for children who are enrolled in a managed care organization versus fee-for-service. So children who are enrolled in managed care organizations are just they don't have as many special health care needs as children who are enrolled in fee-for-service. So children who are in the fee-for-service program who are not enrolled in a managed care organization are children with special health care needs, and they are typically enrolled in a home and community-based waiver, meaning that they may meet a level of care for a nursing home. So you would think that, of course, their diagnosis codes and services will be a little bit different from managed care, but I think they're very telling. If you look, for example, at the top diagnosis codes for children in 2020, routine child exam was the #1 for children enrolled in managed care organizations, where autistic disorder and developmental disorders are top for those children in fee-for-service. So as we talk about preventing risky behaviors, I think that when children, it's very important to look at those very distinct populations. Again, prescription drugs, some of these are mainly asthma for the fee-for-service population and ADHD, in both populations. So again, some of these medications, I think, very telling on the difference between those children who are served by managed care organizations and those children who are enrolled in home and community-based waivers. The procedure codes, as you can tell, again, office and outpatient visit is the top one for children enrolled in managed care, whereas children who are in our home and community-based waiver, their top diagnosis code was self-care and management. However, I think if you look at this, I was very surprised myself when I started looking at this information. If you look at the bottom fee-for-service, that very last procedure code is treatment for alcohol and or drug services, which was very surprising to me. And when we talk about preventing substance use, risky behaviors, again, I think in children, we need to definitely separate those populations and figure out how we can best identify interventions for their specific needs. So children who are enrolled in Medicaid who have had a claim for the past 3 months, as you can tell, a significant amount, roughly average right around 70% of children have received some sort of service in Medicaid in the last 3 months. So going forward, the Department for Medicaid Services has a 1915C waiver. It has actually it's out for public comment right now. And what this waiver is designed to do is to provide substance use disorder treatment for individuals who are incarcerated. So the Department for Juvenile Justice also has children who are considered incarcerated even while they're in the custody of DJJ. So the reason that this is important is because Medicaid cannot pay for services for those individuals. So we thought as we were doing this waiver to provide substance use treatment for incarcerated individuals, it would be very important to also incorporate those children who are in the custody of DJJ in this initiative. So there will be more forthcoming on that. We are also in the process of doing a data exchange agreement between the department and the Department for Community-Based Services that will allow caseworkers to see children's medical records. So these are specifically to foster care children. So for example, a worker may get a notification saying that one of the children that they are managing has either had their immunizations, for example, or they may get a notification saying that they have had an emergency room visit. We're also working on an annual report that we will specifically be outlining some of the child-related specific initiatives that we are looking at. And what the purpose of the annual report is to get information out into the public hands so that you can see what's going on in Medicaid, what services are we covering, where are children receiving services, what are their top diagnosis codes. And we hope that this first report, which will be out hopefully by the end of this year, will serve as a baseline to help guide us as we move forward to identifying issues and concerns that related to children's health and where we can put some interventions in to reduce or prevent some of the risky behaviors. And we want all children to lead their best lives. So in addition to the physical health services that Medicaid provides, we also provide behavioral health services. Again, a very comprehensive set of services specifically designed for children, and we look forward to identifying some of those needs as we go forward and building a better healthcare delivery system aimed specifically at children. Thank you so much.
Thank you, Commissioner Lee. Next up is Dr. Allison Miller. Dr. Miller, an early childhood family learning specialist, is with the National Center for Families Learning. She provides professional development and technical assistance to early childhood programs in the Jefferson County Public School System in Louisville, Kentucky, and specializes in accelerating language development in children ages 0 to 3 and in closing opportunity gaps. Dr. Miller has more than a decade of experience action of Southern Indiana Head Start and a preschool director in Harrison County, Indiana. Dr. Miller?
Yes, thank you so much for having me. I'm really excited to be here today. And I just wanted to share a little bit about my own experiences and some of the tools that I use when I'm working with schools in JCPS or with other Head Start programs within the state of Kentucky. And just on how we can focus a little bit more on that brain piece in children, especially in utero between the ages of 0 to 3, and then how that sets you up for success later on in life. So when we take a look at this, the brain and social emotional learning are very closely connected. It is the foundation for the social emotional growth of a child, and that builds the blocks for physical, cognitive, and language growth. And so any trauma that a child has, either physical or mental, that's going to affect their well-being. And so it's ultimately going to result in delayed social skills and an emotional development. And in some cases, this is a very small delay. And in other cases, we know that it can be just much larger and it's going to involve, bigger interventions down the road. So when we look at the brain, we know that the brain rapidly develops from birth to 3. And then this statistic is always something that is just really powerful for me that I like to share with people, that by the age of 3, the brain has grown to 80% of its adult size. And so when you're thinking of all of those connections that a child is making in utero and then from 0 to 3, this is really a prime time to be looking into how we're interacting with the child, how we're promoting that language and that literacy development, and how that's going to set them up for success later on down the road. And so then during that time, the brain is building pathways. And so we like to think of this as roads. It's creating these connections and it's strengthening them, but it's also going to prune those unused roads. So anytime we're making a new road to go somewhere and we're connecting all of those little synapses, we are, focusing on whatever it is that we're doing. So if it's a positive emotional thing that we're focusing on, then the brain is going to make that connection and it's going to get stronger. If it is a negative connection, it's still going to continue to get stronger. And so what we want to do is to focus on building up these children from birth until 3. So that way the used pathways are the ones that are positive pathways for, a healthy child, and that we're not focusing on the things that can be negative later on down the road. And that's where things like the ACEs, which I think we're going to talk about later on here with someone else with the adverse child experiences, can come into play, because we know that children that have a lot of trauma are going to have more unused pathways because their brains are going to be focused more on the trauma and less on the other skills that they're needing to grow. And so on this slide, I just talked about the things that are needed for brain development. So when we take a peek here, we can see that we need things like oxygen, protein and nutrients, sensory stimulation, activity, and social interaction. And that is all needed in utero and on up all the way into adulthood. So if you have great connections with these things early on, that's going to build that brain. But any brains that are exposed to other barriers are going to have a harder time growing and developing. And so this includes things like lead, mercury, neglect, abuse, and chronic stress. And so now more than ever that we're at home and trying to make the best that we can with our COVID-19 situation, we really need to be focusing on bringing down that chronic stress and focusing on making the brains of our children a little bit more satisfied in terms of social interaction and that sensory stimulation, so that way that chronic stress isn't causing their brains to be stunted. And so when you think about what your child's brain needs, we want to think about things like playfulness, connection, positive touch, eye contact, encouraging conversation, and those stop-and-go games for impulse control. And so if you're a parent that's sitting here at home, or if you're a teacher and you're wanting to do something that's going to better engage your children, I would encourage you to just kind of take a look at this list and to think about all of the times that you have these opportunities throughout your days to embed these with your child. And so when you think about that playfulness piece, it's just as silly as getting down on the floor and playing with your child, whatever age they are. They love to be silly and they love to play. With older children, you just have to kind of engage them a little bit differently. And that connection piece and that positive touch are so, so important at any age because it really is forming those synapses and it's growing that brain. And so now, especially when children are at home in some cases and they're not able to be out socially with their peers or with other adults, we really want to continue that connection and that positive touch at home because their bodies are actually craving it. And then things like eye contact is something that's always a good consideration. We know that some children might not be as comfortable with eye contact, so that's always something to take into consideration. But most children are going to enjoy some form of playful eye contact with you throughout the day. And then just that encouraging conversation. So what we speak into existence is what our children are going to internalize, and it becomes their own constant like I messages. So if you're encouraging with your child at home, whatever their age, and you're using those growth mindset things like keep trying, you'll get better, you can handle this is hard, but that's okay, we can get through this together, your child will internalize that, and that's going to grow in their brain as well, and to really help them grow into healthier adults down the line. And then those stop and go games, the ones that immediately come to mind for me are things like red light, green light with your child. That really prunes the brain for impulse control. And we know that with many children, I've got a 4-year-old at home, that impulse control is something that we have to, work on a daily basis. And so when you're doing things that really get the brain into thinking and pausing and taking a second to just take a breath and to breathe and to think about what's going on, you're going to be building that impulse control for later on down the line, especially for when they're older and they're in situations where they really are going to have to stop and assess the situation. And so then we get a little bit into trauma, and I wanted to touch on the trauma piece a bit because trauma negatively impacts that social emotional growth, which we've discussed. But there are some things that we can consider to help children that are experiencing trauma or have experienced it in the past in terms of making those connections and really helping to grow them. And so the first of the 5 things that I wanted to talk about today is knowing your own triggers. So when you're interacting with a child, either as a caregiver or as a teacher or as another professional in their life, knowing your own triggers is going to be really important here because you can't expect a child to be any calmer than what you currently are. And so if you're upset and flustered and flushed in the face, they're also going to be feeding off of that subconsciously in their brains, and their bodies are actually going to mimic that as well. So as an adult, it's important for us to just stop and take that big, deep breath, and that takes us into that second thing that I'm going to talk about today, which is to model breathing and calm for your child. And so this is just a great time when you do find yourself in a stressful situation or, I know that I have been very burnt out over the last couple of months, as we all have, just with different things at home with our children. It's important to just take that big, deep breath in through the nose and out through the mouth, and to model that for your child and to really get them into taking those deep breaths with you so that you can both kind of co-regulate and calm down together. And the one thing that we do know about children from birth until 3, and then even for those preschoolers and kindergarten and first graders, is they require co-regulation. Their bodies are not made to regulate on their own, and so they need you to help and to model for them. And so that moves us into our third point, which is notice, don't judge. So if you have a child that is in emotional distress or has experienced some form of trauma and they're acting it out in some way, we don't want to judge the child as bad. And so that, again, goes back to what I was talking about a few moments ago of those I messages that are internalized. We don't want our child to be thinking, I'm bad, or I'm not good, or I'm not worthy, or I can't handle this. We want them to be thinking about how they can move forward and grow from the situation. So if you see your child upset, notice, just say things like, I noticed that your face is really flushed, and I noticed that you're angry. You're angry because you wanted something and you couldn't have it. But don't judge the child because of that. And so then we want to move into the last 2 steps, which is just kind of de-escalating the situation, and that is finding something that you have in common with your child. Now, for our caregivers out there, this is probably a little bit easier because you're living at home with your children, where you might see them a little bit more frequently than a teacher would. So really just come up with something that is you have in common with your child that you can go back to day after day. For my little guy, he's into Paw Patrol right now, and as much as it's not my favorite thing, I know that's his favorite thing, so we make a game out of it and we play together. And so finally, that just goes into constantly and continuously seek that connection. A connected child is going to be so much better in terms of those brain connections than a child that's not. And we know that children's brains are always searching for some type of connection. And so at the very least, the child's brain is programmed to think any connection is better than no connection. And so if we're not giving positive connection at home or in the classroom, then children are going to naturally seek out that negative connection, and that's not something that we want. So then I wanted to talk a little bit today about recognizing implicit bias and just some of the things that we have been working on within NCFL to help our teachers in JCPS and some of our Head Start teachers. And it's just the conversation that we're having right now is that we all have a level of bias. And so we need to recognize that and embrace it, so that way we can meet the needs of all of our children. And so we know that children experience social emotional growth differently. And so factors such as poverty, race, language, those all influence a child's social emotional growth. And so I did pull an article from the NAEYC to talk about for a couple of slides, and it just notes that African American boys are suspended or expelled at higher rates than their peers for these social emotional reasons. And so we really need to take that into consideration. And the NAEYC actually recommends 5 strategies to create culturally responsive classrooms for children. And this is something that you could also do at home with your children if you're wanting to embed that as a caregiver right now. And so the first thing that you want to do is you want to learn about your children and your families. And so this includes if you're able to do an ACEs with your families and to learn about what kind of trauma the child's experienced or what kind of trauma the families have experienced, that would be really helpful here for you to get a better idea about what this family is coming into your situation with and how you might be able to better support them. And then what you want to do is you want to develop and teach your expectations based on those family needs. And then when you're in the classroom or when you're a caregiver, you always want to take the child's perspective. So if a child has experienced some sort of trauma, or if they have come from a family that is just more culturally diverse than what you've experienced in the past, we want to make sure that we're looking through the lens of the child and their perspective. And then you also want to teach and model empathy. And that's really important because children just aren't born with this idea of empathy ingrained in them. They need to be taught how to share. They need to be taught how to care for one another and why that's so important. And the only way they can be taught those things is if you are modeling them with your families. And so then the last thing that we want to talk about is using that group time to discuss conflict. And then I did share a couple of things here, which I'm not going to go too much into detail just because of time, but we have these diversity-informed tenets that we have been talking about at NCFL, and they were developed to kind of embed dignity within our families. And so they are strategies that we use in addition to 4 education goals to foster anti-bias. And so I have both of the sources in here, and we can circle back around to those for questions later on. But here on this last slide, I have the 10 tenets and the anti-bias education goals. And so these are just things that we would suggest if you're trying to be more diverse and to really represent that dignity and to help your family to move on into these. And so one thing that I've done with some of the schools that I've worked with is that we might pick one of these things to work on throughout the year in a classroom. Or if you're with an organization, I would recommend just taking a look at what you're already doing well and then pick one that's newer to you that you want to do a little bit better. And so this last slide is just my information if anybody needs to get into contact with me, and I'm going to wrap up there. Thank you so much for the opportunity.
Thank you, Dr. Miller. Our next speaker, Dr. Anthony Zippel, is a founding member and consultant with the Bounce Coalition, a nonprofit organization working to reduce the incidence and impact of adverse childhood experiences, referred to as ACEs. Dr. Zippel consults, teaches, and coaches in areas related to resilience, the use of positive psychology interventions in clinical settings, and the development of innovative human services companies. He is currently a professor at Eastern Kentucky University Psychology Department and an executive in residence at the University of Louisville School of Public Health and Information Services. From 2011 to 2018, Dr. Zippel was the president and CEO of Cornerstone, Kentucky, and responsible for $175 million of direct and contracted behavioral health services. Dr. Zippel?
Thank you, and it's great to be here with everyone. And I want to thank the Foundation, not just for hosting this event, but for the work that they've done in supporting Bounce and helping to launch our work now more than 6 years ago in the area of adverse childhood experiences. You know, it's no surprise to anybody here on the call, but Kentucky struggles with public health outcomes. We have the highest rate of child abuse in the nation, drug abuse, suicide, poverty. These are all significant problems in the state of Kentucky, and we face tremendous challenges in trying to meet them. One of the things that we need to understand, though, is the roots of many of those challenges, I think, are found in early childhood experiences, or ACEs, as was mentioned in the last presentation. Now, when I talk about ACEs, what I mean are traumatic events that occur in childhood between birth and 17 years of age. These are big things that occur, difficult things that occur that go on for a long time. And ACEs are important because they are a measure of individual health risk, and they're also a measure of community health. So they're really useful in clinical context and really useful as a public health measure as well. So when I talk about traumatic events in childhood, I mean things like physical abuse, emotional abuse and neglect, and household dysfunction. There is a standardized ACEs survey, 10 items that measures these. You can find this online if you Google adverse childhood experiences assessment, something like that. It'll pop up for you. And it looks at these 10 different categories of things that occur in childhood that create difficulty for the child. But what is most fascinating about these adverse childhood experiences, and so useful for us to know in this context, is that these early childhood experiences have lifelong adverse impacts. The number of bad things that occur for us as adults is predicted by the number of adverse experiences that we had as children. So, for example, a single adverse childhood experience, as measured in this scale, increases the risk of mental illness by 30%. You know, a child who has 4 or more of those ACEs is 32 times more likely to be labeled with a behavioral or a cognitive problem. And when you get into really big numbers, if you have 6 or more of these 10 ACEs, it predicts a 20-year shorter life expectancy. So that's a really big deal. So these are dose-specific kinds of things. The more of these things that we have in our lives as children, the more bad stuff that we're at risk of happening, the greater the probability of bad things happening to us socially, economically, and health-wise as we move into adulthood. This is especially important in Kentucky. In the United States, about 2/3 of the population has at least one adverse childhood experience. Here in Kentucky, about 2/3 of the population has at least 2. We're one of the national leaders in ACEs. And again, when you look at the adverse health outcomes that we know occur in Kentucky, it's not a surprise that we also have high levels of adverse childhood experiences because they're closely connected. ACEs are a predictor of these bad things that occur in adulthood across the population here in Kentucky. We also know that there are other things besides the 10 that were listed on the ACEs survey. We know that racial trauma, gender discrimination, neighborhood environmental conditions like violence in the neighborhood or pollution are other sources of trauma. And so to the extent that you see in the ACEs survey big numbers, it may be even worse because these things aren't always included in the ACEs survey. And we also know that COVID has been a huge amplifier for this. You know, the research is yet to be done on the impact of COVID as an adverse childhood experience, but we know that the isolation associated with COVID, the disruption, the increased family stresses are going to at least be amplifiers for underlying adverse childhood experiences and may be worth treating as a separate adverse childhood experience just in itself. The cost of these ACEs is huge, and we're talking about billions and billions of dollars. In California, they estimate that reducing the average number of ACEs by 1 would result in multiple billions of dollars of savings in the state of California. At a personal level, we know that ACEs drive poor mental health, increased substance abuse, overall poor health, lower productivity, shorter life expectancy, all of these things that have personal clinical and personal financial costs. And these add up at a community level. As a community, we have higher health care costs. And you heard in the initial presentation from Commissioner Lee, what we spend on health care through Medicaid, that is amplified by high levels of adverse childhood experience. It increases the odds of criminal justice behavior and costs. It reduces the quality of education and educational outcomes. The workforce becomes less effective. These things all have community impact, both in terms of quality of life and in terms of economic circumstances. So the cost of ACEs is huge. Paying attention to doing something to reduce ACEs and mitigate the effects of ACEs has tremendous individual and community payoff. It's important to note that ACEs aren't just individual behavior, that ACEs are rooted in inequality and in social context. If you look at this slide and you think of this tree as, the place where ACEs flower, things like maternal depression and divorce and so on, underneath that, in the roots of that tree, you have things like poor housing quality. You have things like community disruption and discrimination and poverty. This is the soil that grows adverse childhood experience. So if we're going to really intervene in preventing bad things for kids that turn into bad things for adults, we need to work not just at a clinical level, but we need to work at a social policy level as well. Now we know that ACEs, trauma, can either beat us down or it can actually lead to growth. If you listen to people like Oprah Winfrey, who talks quite openly about the trauma she experienced as a child and how she overcame that and it helped her to be the person she is today, we know that we can overcome this kind of trauma that occurs in childhood and do better. The way that we do that is by changing our thinking and our social policy about it. If we start from the assumption that when we see bad behavior, it's because something's wrong with that person, our tendency is to say, well, you deserve the bad things that happen to you, and we're going to punish you for behaving badly. We need to shift that into asking, what happened to you, as opposed to what's wrong with you. And we ask what happened to you, we're more likely to provide supportive and educational interventions and help reduce the impact of these bad events. Interventions for ACEs fall into two general categories that I think are important for today. On one hand, interventions that happen at a community-wide level become important. We should be doing universal screening for ACEs as a measure of community health. We should be working on restorative practices in the criminal justice system as opposed to just punishing people. Economic inequality, food insecurity, healthcare access, quality of education, violence prevention, and racial justice are all social policy-driven things that we need to pay attention to if we want to reduce the number of ACEs. But we know that no matter what we do with that there's still going to be trauma. I mean, trauma is a fact of life, and everybody has bad things that eventually occur. So even with our best policy work, there will still be ACEs that occur, and we need to do things that mitigate the effects of those ACEs. One of the first things is everybody ought to know what their ACE score is, just like you know what your blood pressure is, you know what your cholesterol level is, as a way of saying, I want to do some things to mitigate risk. We should know what our ACEs score is. We need to teach resilience strategies to kids and to families. We need to improve safety for them. We should need to focus on basics like nutrition and exercise and sleep. We need to connect kids to caring adults because we know that the single biggest thing that reduces the impact of ACEs is connection to an engaged, caring adult. So these are the kinds of things we can do at an individual level that reduce the impact of ACEs. So community level and educational level have great payoffs for us when we do those. So in short, ACEs are just a fact of life. They happen commonly, and current events in our world today amplify their impact. They happen to us personally, and they affect us as a community. They drive private costs and they drive public costs. And if we want to do something to make it better, we've got to focus on policies and supports that reduce ACEs, and we've got to focus on early intervention in a way that mitigates the effects of ACEs and reduces the long-term cost. So that's what I've got to say about ACEs.
Thank you, Dr. Zippel. Next up, our speaker is Dr. Julia Richardson. Dr. Richardson has been a pediatrician for 25 years and is active in child health advocacy at the state, local, and national levels, and has a particular interest in working with refugee and immigrant families. She serves on the board of directors for the Kentucky Primary Care Association, Doctors and Lawyers for Kids, the Food Literacy Project, and the Jewish Heritage Fund for Excellence. She previously practiced in McKee, Kentucky at the White House Clinic in the Appalachian Mountains for 6 years. She has been in Louisville for 17 years taking care of children and families at the Family Health Center's office in South Louisville. Dr. Richardson?
Good afternoon, everybody, and thanks to the foundation and to all the speakers. It's been so interesting, and I feel like I'm really building on the comments that have already been made around, you know, the number of kids in Kentucky on Medicaid is so high. Those kids really need help, and families need help accessing services. We know that we have to champion children's rights. This is all a children's rights issue, and when we approach it from that perspective, I think it gives us new insights. And then, of course, all of the work we do now is luckily informed and seen with a trauma lens. And so I think all of those things are important, and enjoyed listening to the other speakers. So I'm going to talk a little bit about the work that I do and talk about some really practical interventions that we do as pediatricians. And I'm going to use the word pediatrician, but I mean all child health medical providers when I use that term. So instead of saying all of the words, but that I do mean all child health medical providers, family medicine, physicians, nurse practitioners, physician's assistants, all of us doing medical care. So this is a quote that's really staying with me these days, and it's from Dr. Mona, who was one of the pediatricians that was vital in the Flint lead crisis. She said, rather than hoping a child is tough enough to endure the insurmountable, we must build resilient places, healthier, safer, more nurturing, and just, where all children can thrive. So what I'm going to talk today about are what are adolescent risky behaviors, and why are adolescents at risk for risky behaviors, and then what role do we as child health medical providers play in helping to prevent these risky behaviors. So if you look at the Youth Risk Behavior Surveillance System definition of risky behaviors, so they define it as behaviors that contribute to unintentional injuries and violence, tobacco, alcohol, and other drug use, sexual behaviors that contribute to unintended pregnancies and STIs, as well as unhealthy dietary behaviors and physical inactivity. And then many references add truancy to that list of things that eventually shorten their children's lives or cause significant morbidity. So that's what risky behaviors are. So what do risky behaviors mean in the context of an adolescent? So this is a model of risk and protection that I think gives you a nice framework of those macro level environmental factors, as well as those sort of personal level factors, response and outcome. And so we've been talking a lot around that stress bubble, right? We're talking about family and peers and school and neighborhood and poverty, discrimination and inequality. But I just wanted to take a moment and mention risky behaviors in teens are normal. We would worry if teens didn't take some risk. It's part of their brain development. And so we do have to look at risky behaviors in that context, preventing them and mitigating the impact of factors that increase the risk, but also respect that it is a healthy risk-taking time as well. So what do we do as pediatricians? What are we working towards? So basically we meet a baby at birth and we say goodbye to them at 21, and we're going to try for 21 years to help make them healthy. So what do we do? So we work on early identification and treatment of both physical and behavioral health issues. We really promote optimal mental health and increased family bonding and family stability, family resiliency, and decreasing the incidence of abuse and neglect. So that's what we get up and do every day. So, well, what's special about us? What's our role? So we have early and frequent contact with families and children during those early years. We're considered a very trusted source of information and advice, and we provide evidence-based interventions throughout childhood to help families be strong. Okay, so I'm going to talk a little bit about some of the evidence-based interventions that we do at these ages, but also some gaps and opportunities. So prenatal, we're not there. We don't have a huge opportunity for the most part to impact prenatal time, but it's vital. Birth to age 3. So interventions that work, just a couple that we know of, are early identification and care for children with developmental disabilities. We do that a great deal. And we also do postpartum depression screening as a core part of our work. So what are some opportunities in the birth to age 3 years in Kentucky? So first steps was already mentioned, very important intervention for children with developmental disability, but in Kentucky, you have to have a significant developmental disability to qualify. Children with mild and moderate disabilities often can't qualify for first step services. In other states, there are different qualification guidelines. So that's certainly an opportunity to look at how can we help more children with mild, moderate delays, because that's what First Steps is good for. It's a family-focused intervention with therapists, but we have a great opportunity there. We also have an opportunity to increase access to care for mothers who have mental health concerns as we're screening them for depression, because we know that maternal depression is linked to adolescent risky behaviors. And this reference from pediatrics says adolescents exposed to maternal depressive symptoms during middle childhood were more likely to use common substances, engage in violent and nonviolent delinquent behavior, and have earlier debut ages for cigarette, alcohol, marijuana, and hallucinogenic use. So we know this intervention works, but it's not working as good as it could because of lack of access to services. So 3 to 5 year olds, one of the interventions that work that we do in pediatrics is called the Reach Out and Read program, and it's a early literacy promotion program, birth to 6 years, that families get free books and early literacy counseling. We know it works, but Reach Out and Read has lost basically all of our national funding and the Kentucky state funding because it was tied in tobacco settlement dollars. So we can't buy books anymore. So the program is very difficult to do. But we know that Reach Out and Read has an impact on decreasing truancy and school dropout rates. Here's an article from Advances in Pediatrics saying that children's literacy skills at school entry, kindergarten, and first grade predict their later reading success. And we know that reading skills at 11th and 12th grade can be predicted from reading skills in first grades. And we know those kids that struggle in high school, higher dropout rates and truancy. So this is a program that works, but is difficult to find funding for. So ages 5 to 9, an intervention that works, and this is for all the ages, but a medical legal partnership. So what a medical legal partnership is, it's embedded lawyers as specialists in healthcare settings. So when complex and intractable problems like illegal evictions are detected, clinical staff can refer patients directly for legal services. And the services that medical legal partnerships address are economic stability, education, social and community context, neighborhood, and physical environment. So a lot of housing, substandard housing issues. So what's an opportunity here? So funding streams in Kentucky are very unreliable for medical legal partnerships. They're not linked in to other social determinants or social drivers of health efforts or into health funding or health payers like it is in other states. So we know that inequality and poverty are important factors leading to higher incidence of risky behavior in adolescents. If you go back to that first framework, these are definitely drivers of risky behaviors. And again, lots of literature supporting medical legal partnerships' impact on mitigating these things that we saw on that first slide that lead to stress and risky behaviors in adolescents. So this is an example of one co-located in an office like ours that treated a large cluster of poor quality substandard housing. So not just one-on-one with each family, but can impact entire communities. Age 9 to 12, again, this is an intervention for all ages, but it's people have heard of patient-centered medical home. So this is not a place. Medical home is not a place. It's an approach. It's a very complex system. It's quite expensive to provide primary care for children and adults. And so gap and opportunity here is effective payment for these systems is lacking for the most part. Care coordination is expensive. Community health workers, therapists, case managers, for the most part, they're not available to the extent they need to be. But we know that medical homes optimize the physical and mental health of children. And again, another article that youth enrolled in patients in our medical homes had a greater likelihood of receiving preventive services and improving their health. So back to prenatal really quickly. Of course, I couldn't leave it off because then we see the teenagers who are pregnant, and we work with pregnant women all the time in the office. But we know that interventions that work are high-quality, accessible prenatal care with support from doulas and other birth support people, birth spacing, which is access to family planning, and the home visitation program that Lisa Lee mentioned. So some gaps and opportunities here. Doulas in Kentucky aren't supported by the healthcare system as far as payment. We know the outcomes are much better with doula support. Access to timely family planning is really challenging, but also expanding access to home visitation beyond first-time parents and beyond that 2-month window postpartum. So you can get in when you're pregnant, but by the time the baby's 2.5 months old, the program's closed. And so we could get better access for babies that are older. For a program like HANDS would be really important for families. So these are the ages we impact as children providers. I wanted to point out discrimination and inequality are key elements of the development of risky behaviors in adolescence. Everyone has seen this representation of reality, equality, equity, and liberation, just to reinforce that point. So we talked about risky behaviors, a framework to kind of hang our hat on as far as adolescent risky behaviors and what we do in the office. So thank you for including us. We do this work all day long. We feel it's really important and evidence-based work, so we appreciate being part of the conversation. And remember, we're an ally out there doing this work, so pull us in to help you do the work that you're doing as well. And again, just reiterating Dr. Mona's quote to build, I'm tired of telling children to be resilient. Thank you.
Thank you, Dr. Richardson, and thank you to each of our presenters. I'm going to kick off the Q&A session with a question that I have. This came in right after Lisa Lee's presentation, so she may want to answer this. Will this access for the case managers also alert them if a child is due for immunizations or any specific treatment previously started?
Yes, we are hoping definitely as we move along that the caseworkers will tell us specifically what information would be most helpful for them to have. So as we move forward with this data sharing agreement, we will definitely circle back with all of our caseworkers periodically. We will have meetings to make sure that every bit of the information in there is useful to them and that we're doing everything we can to identify either gaps in services or upcoming services that children need. And again, this is for our foster care children. So definitely will be an ongoing project and updates as needed to the data that the caseworkers can have access to.
Thank you. And we have another question. Dr. Miller mentioned chronic stress as a barrier to brain development. Can positive stressors, moving to a new home, new school, striving for high scores academically, sports, etc., if chronic, cause barriers to brain development as well?
Hi. I would say it is always going to be how you're handling those stressors. So chronic stress is any time we think about those things like blood pressure, like over a long period of time, or for children that are in those achievement things. I know I was one of them. I was under some positive stress to continue to trying to get better and to learn. And so it's really how you're handling it as a family. So if you're a parent in that situation and you're moving to a new home, yes, that is stressful, but how you're talking about it and phrasing it is going to impact how your child's brain processes that. And then again, it becomes that I message. So if it's a positive move, but we're handling it in a negative way, or we're really stressed out about it all of the time, then your child will begin to associate, moving or other things like that in a negative light. But if you're talking about, yes, this is really stressful right now, but we get to move because it's a better job for our family, or it's a better home for our family, or that type of thing, that's going to be a really positive way to handle that, in a way that the brain is going to rewire itself to say, yes, this is stressful, but I know I can get through this stress because I've gotten through it in the past, and we've talked about it in a positive way.
Yeah, I think
Thank
that
you,
just to build on that, it's stress in and of itself isn't necessarily bad. I mean, we need a level of stress in our lives that improves our performance when we're a little bit nervous, for example. The challenge comes up when it's a really big deal that goes on for a long time, and there's not adequate support around us to cope with it. And so I think that's a great example, a great answer that Allison gave. It depends on whether you've got enough support around it. It depends on how long it goes on. So stress in itself isn't bad. Stress that becomes trauma is.
Thank you, everyone, for your input and for your questions and answers and information today. That's all the time we have for live questions, but remember, if any questions come in that have not been answered, we will be responding to you in the days ahead. This webinar will be posted at www.healthy-ky.org later this week. I joined the Foundation for a Healthy Kentucky and Kentucky Youth Advocates in inviting you to share the link with your networks. The next webinar in the Bost Health Policy Forum series is Monday, November the 9th at 1 p.m. Eastern. The title, Promoting Healthy Lifestyles Through Nutrition and Physical Activity. Our speakers will discuss community, school, and home-based programs that successfully improve nutrition and increase physical activity among children and youth in Kentucky. We look forward to seeing you then. Thank you, everyone.
Thank you.
Thank you for having